So with that, what I'm going to talk about is a little bit about our work with the Stanley and Elizabeth Starr Precision Medicine Center of Excellence on Mood Disorders, and our work to, I'm going to focus in on our work to leverage the electronic health record data to support this idea of a learning health system for mood disorders, and go from there. So first off, disclosures, none that I need to disclose, no conflict of interest. And the goals of the talk, which also double as an outline for the presentation. I'm going to touch on 4 points throughout the presentation. The first, real briefly, just introduce the concept of precision medicine. We're all familiar with it, and I know Dr. Potash presented on this in the grand rounds not too long ago. But I do just want to show 1 or 2 slides to set the stage. Then second, I'm going to quickly highlight infrastructure that's being built here at Johns Hopkins for advancing precision medicine and the goals of precision medicine. And then third, I will talk about and describe goals of the Precision Medicine Center of Excellence on Mood Disorders, which, as Dr. Potash mentioned, I co-direct. And our efforts to build on this concept of a learning health system to achieve those goals. And many of you may have heard me talk about learning health systems ad nauseum, perhaps, but we'll talk about it a little bit more now. Then fourth and finally, and most of the time will be spent on presenting some results from data from ongoing analysis of a patient registry of electronic health record data that we've brought together on patients with mood disorders across the Johns Hopkins health system as a starting point for building that learning health system on specifically mood disorders, which we're interested in. And I'm going to quickly talk about 3 driving projects, try to make a couple of points, and then end on a few lessons from there. So just to jump right in, precision medicine, again, not to spend too much time on it, we are all familiar with what precision medicine is. And if you ask ChatGPT 3.5, the cheap version, this is the definition that you'll get, which I think is as most things that you get from ChatGPT, reasonable definition. Precision medicine, also known as personalized medicine, is an innovative approach to medical treatment and healthcare that takes into account individual differences in genes, environments, and lifestyles. And the goal here is the precision medicine is to tailor the medical care and treatment plans to the unique characteristics of each patient to allow for more targeted and effective, hopefully, interventions. Again, a concept that we're all familiar with. The idea of precision medicine has been around for a long time, really accelerated in 2011 with this National Academy of Science report towards precision medicine. They made an interesting point, which I think is worth keeping in mind, that sometimes this definition is misinterpreted as that you can develop and provide unique treatments to each individual, which is not quite right. So the committee recommends precision medicine, which I agree with, and this idea that there are subtypes or there's heterogeneity in patients with illness, and that we want to try to figure out and understand that heterogeneity so we can provide medications and treatment plans and approaches to caring for individuals with, in our case, mood disorders in a more precise, targeted way. Further initiatives that we're all familiar with, in 2015, President Obama started the Precision Medicine Initiative, which was to further accelerate the dissemination of the ideas of precision medicine across the healthcare system. And we're all familiar with the All of Us program that was supported with research dollars to follow 1 million patients across the US. So it is clearly a concept that everybody's interested in. Hopkins actually has invested some considerable amount of time, thought, money to try to provide infrastructure that will allow us clinicians, investigators, researchers in Johns Hopkins to try to advance precision medicine. And you may all be familiar with this InHealth group, which is the leadership across the Johns Hopkins health system that's come together. One of the top achievements, or one of the lead achievements, are things that they produce that I think has real tangible utility for those of us on the ground thinking about patients with different types of illness, is they've built this infrastructure, precision medicine analytic platform, or PMAP, which I'm sure many of you have heard now. This is an infrastructure, it's a cloud-based infrastructure for bringing together the electronic health record data from all our patients seen across the Hopkins health system into one place in a protected environment, where you can also bring in other sources of data on these individuals that we might capture into one place where we can analyze and learn from that data and use that as a way to advance precision medicine in the care of our patients. So it's created the actual computational infrastructure for doing that, but even more importantly, or perhaps as importantly, as a result of this initiative, they've created the policies and the procedures and the workflows for getting the permissions to work with this sensitive data in a protected environment. So the Johns Hopkins Data Trust, which oversees the use of enterprise data for clinical and research purposes, they're comfortable with using this PMAP platform. They've developed workflows for requesting permission to utilize it. And the IRB is also very familiar and comfortable with it, so that now it's much easier, and the work is greatly facilitated to put in proposals to the IRB and to the data trust, say, look, we want to bring this data together on our patients so we can learn for it for X, Y, and Z. And so the combination of the infrastructure and the workflows and the work rules around that have really, I think, created an opportunity for us to try to accelerate precision medicine at Johns Hopkins. The Indian Health Organization has established these precision medicine centers of excellence in a variety of therapeutic areas. Here you can see the current list. I think this is current. There's about 30 now precision medicine centers of excellence. And you'll see that there are 4 from the Department of Psychiatry and 1 that's in progress to support work in psychosis, Alzheimer's disease, mood disorders, schizoaffective disorder, and Huntington's disease. I'm going to talk about our work with the mood disorders, but I did want to make the point that the precision medicine centers of excellence are trying to work together to create a community of learning together of how to take advantage of the resources that are available to us now to try to bring precision medicine to our particular areas of interest, and to share common infrastructure and ways of approaching these challenges. This figure that you see here I got from courtesy of Dr. Potash, but really the credit goes to Dr. Russell Wallace, who I think was the one who came up with this idea of the flowering of precision medicine centers of excellence across the psychiatry, and this idea of shared infrastructure, which I think is a really nice figure that gives that idea, that concept. We refer to ourselves, or I refer to this as the PMC, Precision Medicine Center Psych Cluster, and there's a variety of activities they're trying. As I mentioned today, I'm going to focus on the Mood Disorders Center, and this is a figure of to represent the folks that have been involved in coming together as part of the Precision Medicine Center of Excellence in Mood Disorders. We have been officially termed the Stanley and Elizabeth Starr Precision Medicine Center of Excellence in Mood Disorders. This is thanks to a generous gift from the Stanley and Elizabeth Starr family. We are also, every good center has to have a logo. We're workshopping different logos. This is the latest logo. I'm not sure if I'm allowed to use it because it hasn't been formally established, but if you're so inclined, you can send us an email and see what you think of our logo, because we know how important that is. But really, more importantly, here are the folks that have come together. It's kind of a class photo album, if you will, of folks who have been joined together to try to establish the Mood Disorders Center of Excellence. You can see here familiar faces, senior leadership. We have some young fellows who have joined on with us and are doing work with our group. We have some great colleagues across the Mood Disorder Center, and there's others as well not represented here. And then on the ground, we have a great informatics team who I'll talk about a little bit up here. I'm not mentioning names just in the interest of time, but I did want to show their faces. And we have a great team of research coordinators that are helping us with the different studies. And as Dr. Potash mentioned, I co-direct the center along with my colleague, Dr. Fernando Goaz. And here's our photo from when we graduated, apparently in high school, with dreams of leading a precision medicine center of excellence. I think we're going to stick with these photos. They are a little bit outdated, but I like the fact that I have a lot of hair, so I'll keep that. So in the Precision Medicine Center of Excellence, we've been really leaning into this concept of we want to build a learning health system for mood disorders as a way of getting us towards Precision Medicine Center of Excellence. So now learning health system is another buzzword that you all have heard me talk about before in other calls, and you've probably heard it from other folks as well. This is a definition that comes from the Institute of Medicine report in 2012, which really, again, accelerated interest in this idea of a learning health system. Just to read it, just because I do think it's a good definition, a system in which progress in science, mathematics, and care culture align to generate new knowledge as an ongoing natural byproduct of the care experience and seamlessly refine and deliver best practices for continuous improvement in healthcare. There are a lot of figures to depict or represent the idea of a learning health system. This is one that I came up with. I show this to people and they say, oh, it's nice, but they're not quite as excited as I am. I think this actually is a good figure because it captures, in my mind, the key elements of a learning health system. The first is at the core are our patients and the fact that there's different subgroups of patients, we think. It's very heterogeneous, especially when we're talking about mood disorders, depression and bipolar disorder. There's subtypes, there's different trajectories, there's some courses of illness. And that's what we're trying to understand, parse that heterogeneity, which will be key to providing precision-guided medicine and care. But the notion is as we're providing care to these patients, we want to convert practice, clinical practice, into data. We want to convert the information that we get as we're following patients to data that we can study and analyze. And we want to take that data, we want to bring it together somewhere where we can analyze it with these increasingly sophisticated analytic methods and learn from it, derive lessons from it, and then take those lessons and turn knowledge back into practice. And the idea is that this is a continuous sort of process. As we provide practice, care, we're gaining data, we're analyzing it, and we're converting back into improved care, knowledge to practice. And hopefully you can see that this is meant to be a sort of forward virtuous cycle of moving forward and improving care for our patients. And so we have leaned into that idea, as I said, in the Precision Medicine Center of Excellence of Mood Disorders, and we are actively engaged in a number of initiatives to implement that idea. And these icons represent the different ways in which we're trying to implement this idea of a Precision Medicine Center of Excellence on Mood Disorders, utilizing a learning health system. And we're active within all these levels. Today, I'm actually going to just focus on this one side of the equation or the formula, but I did want to quickly highlight some of our work across each of these aspects of approaching the problem. So first of all, the electronic health record data, the rich source of information that we're collecting on our patients. We want to try to leverage that. And we have a series of studies, and in fact, that's what I'm going to talk about for the bulk of the talk today, which I referred to as our PMC Mood, Precision Medicine Center Excellent Mood Disorder, PMAP registry studies, where we're taking that EHR data and trying to convert that practice into data and learn from it here in this PMAP environment that we've pulled together. So I'll come back to this notion. We're also engaged in randomized trials embedded in the clinical care. We have a number of studies where we're studying things like SAINT treatment, which is a accelerated theta burst stimulation treatment that's guided by functional MRI for patients with bipolar depression. We're involved in a number of studies looking at comparative effectiveness of ECT versus ketamine for depression and suicide. Again, these are just some of the current ongoing studies across the Precision Medicine Center of Excellence, trying to leverage different ways of understanding and learning from our patients. As Dr. Potash mentioned, we have a really active program of research in omics, trying to understand omics data to learn about this underlying heterogeneity. I'm not going to talk about it here, but we are involved in a genetic study of extreme depression by recruiting patients from ECT and other neuromodulation clinics across the country and around the world. We're also involved in a large collaboration studying bipolar disorder in East and South Asia with the idea of looking at a diversity of population rather than just Northern European population. We're also involved in a collaboration with the Lieber Institute to leverage their resources of postmortem brain samples to understand not only genetic risk factors, but the mechanisms by which those risk factors that can explain this underlying heterogeneity. We have an active line of research going on trying to understand biomarkers that we can capture. This could be blood-based biomarkers, saliva-based biomarkers. It can be imaging biomarkers, or in this case, EEG biomarkers. We have a pilot study looking at EEG in response to esketamine that we're just getting started. Or other, we have another study with the NNDC and National Network of Depression Studies Centers, to look at biomarkers for response to IV ketamine. So again, a program of research within our center to leverage biomarkers. Finally, we're interested in looking at digital phenotypes, data from your phone or wearable devices that can help us learn about this underlying heterogeneity of patients. EHR data is great for capturing information at the point of contact of care, but we all know we live lives outside of the healthcare system. How do we get information about what's going on with our patients in between their visits to our health system? Well, this digital phenotyping represents one avenue by which we can gather information on our patients to see how they're doing. We're involved with a collaboration with John Toros from Beth Israel and Harvard, who's created this app for studying and following patients with psychiatric disorders. We're also looking at the Aura Ring as a wearable device that can tell us something about how patients are doing and see if that can tell us, give us early signs about the course of illness. We're also involved in a social media study. Can we follow patients' social media? So I haven't gone into detail here, but I wanted to give you a broad picture of the different types of activities that we're involved in to really get as much information about our patients as we're providing care to them that we can convert into data and bring together. But today, in the remaining 30 minutes, I want to talk about our activities to really try to leverage the electronic health record data that we're capturing on patients as we're providing care and how to utilize that. So I'm going to focus on 3 studies, and I'm going to briefly introduce these studies, try to motivate them with a slide or two, and then really just highlight a couple of points. These are works in progress, but I think they're useful case studies about driving research questions that we can start to investigate with this data that we're pulling together on our patients that we're caring for here at Hopkins. The first study, we're going to look at telemedicine use among our patients with depression. In the second study, we're going to look at prescription trends for patients with bipolar disorder. How are we treating patients with bipolar disorder? How does it compare to national trends? And then in the third study, I'm going to talk about a funded project where we're trying to combine randomized trial data and a real world, it's a term you probably heard, EHR data to estimate antidepressant treatment effect heterogeneity. And what hopefully will become clear by the end of the talk is these first 2 studies really are getting at sort of more descriptive. What are we doing with our patients? What's happening with our patients with mood disorders in Hopkins? And it's really this third study where we're taking that next step, where we're going to try to use that information to really talk about then how do we achieve precision medicine. That's what this is getting at, this idea of treatment effect heterogeneity. And so we'll come back to that notion, but hopefully that sets the stage. So real quickly, before I dive into those 3 studies, I just want to talk about this data that we've put together over here in this PMAP platform. We are gathering electronic health record data on all patients with a mood disorder diagnosis, whether it's an encounter diagnosis, billing diagnosis, or problem list of depression or bipolar disorder that is seen across the Johns Hopkins health system, and bring their EHR data, their medications, their labs, their procedures, their encounters together on this PMAP environment. And we have now data, and this stretches back from when Epic was implemented. When it started in 2013 was, I think Bayview was the first hospital where Epic was implemented. I may have that wrong, but it's around 2013 up until the current date. In this registry and the PMAP environment is refreshed monthly. Every month, new data comes in from the patients that we're seeing that meet these inclusion criteria. And we now have data on over 200,000 patients. What I wanted to show here was just taking a snapshot of that data in 2023, from January 1, 2023 to December 31st, 2023. What did we have in the PMAP registry? Well, we had data on a total patients of over 25,000 patients seen across the Johns Hopkins health system, which is represented by this map here of the different centers. I should clarify that we're collecting the data from all departments of psychiatry across the Johns Hopkins health system, as well as the primary care network and the Johns Hopkins community physicians. And that's what's represented here in the map. Over 5,000 inpatient encounters in this year and over 650,000 outpatient encounters in 2023. Just real quickly, without going into detail, you can see around 10% of those patients are a child or a young adult. There's over 25% are over the age of 65. There is a skew to females, over 70%. That's driven largely by depression. If we look at bipolar disorders, more, as we would expect, a 1-to-1 ratio, but driven by depression, where there is a larger proportion of females. With regard to race, there is over 20% of the patient population is Black, 10% other racial and ethnic groups. This is interesting. If we look at the Department of Psychiatry versus Johns Hopkins Community Physicians, it's quite different. In Department of Psychiatry, the Black patients represent around 30%. So it's a very sizable minority of population that is cared for across the Johns Hopkins health system. If we look at those 26,000 patients and break them down, over 21,000 are patients with a depression diagnosis, around 3,500 with bipolar disorder, and then 2,000 with other mood disorders like cyclothymia, dysthymia, mood disorders due to unknown physiological conditions. And then these pie charts represent the breakdown across the main areas where we're providing care. This is Johns Hopkins Hospital. The blue represents the depression. The orange or brown, whatever color you call that, represents bipolar, and these are other mood disorders. So Hopkins, and here's Bayview Medical Campus. And as you can see, around 3,000 patients with depression, almost 1,000 patients with bipolar disorder. Johns Hopkins Community Physicians, these are the blue markers here represented across the area. Around 15,000 patients with depression, around 1,500 with bipolar disorder. Much smaller census in Howard County, suburban, and Sibley, but still contributing a sizable number of patients with mood disorders. Now, what's not represented here on this map is all children's from Florida, but we are also gathering data they are on the same EPIC system, and so we are gathering data from them as well. So first project, so I'm gonna do 3 projects in 20 minutes. I'm looking at my clock, maybe 25 minutes. So again, I'm gonna try to focus on the highlights and try to be efficient with time. So the first study is telemedicine use among patients. Now, we're all familiar with COVID. There was just this rapid transition to telemedicine use. We got funding from InHealth. We were one of 2 precision medicine centers of excellence that got funding to study the impact. Well, what did that impact have on the care of the patients that we were seeing in the center? Here, I wanted to highlight the people who really are doing the work. I wanted to give a shout out to Dr. Catherine Edmond, who's a new assistant professor in the Department of Health Policy in the School of Public Health, who's really been instrumental in leading the charge on these analyses related to this project. Carly Lipton-Smith, who's a doctoral student in the Department of Biostatistics, working with Liz Stewart, a really talented biostatistician. And then these 2 folks who many of you may know, who've really just been instrumental in everything we do in the center. Jason Straub, who's been key in our MyCare initiative that Dr. Potash mentioned, and really key in a lot of the work that we're doing in the center. And then recently, in the past year, Fazil Sapit joined, and many of you are beginning to know him as well. And I can't state enough the contribution that these folks especially have, Jason and Sazil, to really get the work done that we're doing across the center. I'm not going to go through all these. These were the aims of the project as we laid out to the InHealth. What was the impact of that transition to telepsychiatry on process of care? Who's doing telepsychiatry versus in person? And what impact does telehealth versus in person have on things like no-show rates or cancellations or completions? We wanted to study the impact on the changes of content of care. The switch to transition to telepsychiatry, did it change the frequency and duration of psychotherapy visits, changes in medications, or in other clinical quality measures? What was the impact of this transition that came about with COVID on patient outcomes or patient satisfaction? We wanted to look at the impact on proximal outcomes measured by patient-reported outcome measures, where we had that data. This is actually a point. Or other distal outcomes, such as frequency of emergency room visits or hospitalizations. And what was the impact on patient satisfaction? Finally, what was the impact on overall costs of care, both from the institution's perspective and from the individual patient's perspectives? And really then finally, all of these factors, how did they vary between telehealth and in person by patient and other context-related factors? And the idea really motivating this work is, can we understand where is telehealth working for individuals and where is it not? So that maybe we can focus our resources and tailor care to those where telehealth can be an advantage, providing care for our patients with depression. For the three or four slides that I'm going to show here, we're just going to focus on this first aim of this project, where we want to understand the impact of the transition to telepsychiatry on things like no-show rates, cancellations, completions, and how did that differ by patient and other encounter or context-related factors. So this is a consort diagram where we went to our PMAP registry, we established some inclusion criteria to answer these questions. We put in an IRB protocol to say we want to do X, Y, and Z. This is our aims. This is what we want to do, and give us approval to pull data from our PMAP registry, create a projection on the PMAP environment, where then we can go to that environment and work in a protected space where everybody feels comfortable that the data is in a secure environment, there is a reduced risk of breach of that data, and everybody knows there's an accountability of what's going on with that sensitive EHR data. We got approval from the IRB, and this represents the flow diagram for pulling patients. We were looking at patients with depression. This analysis was focused on patients specifically with depression in psychiatry and in JHCP, our primary care network. We were looking around this 2.5-year window around COVID, which was March 2020, because we wanted to study what happened before and after COVID. And you can see there was around over 16,000 patients in psychiatry, over 1 million encounters in this time period, over 50,000 patients in JHCP, and over 4 million encounters. We did some further exclusion criteria. We wanted to remove patients with bipolar disorder. The focus was on depression, patients ages 10 and above, and we were focused specifically on outpatient appointments because we're interested in telemedicine, where it can have an impact. So we're not looking at inpatient, but we're looking specifically at outpatient encounters. And you can see how the numbers get what we're dealing with when we look at this inclusion exclusion criteria. This last box represents if we take these patients and these encounters and we just focus on the year post-COVID to June 30th, 2023, what do we get? And so we can look just at that particular window. We actually do a lot of our analyses focusing on July 1, 2020, which, as we all know, was really March 2020 when COVID happened. But we wanted to allow for some period of stabilization. Things were just wacky after COVID. Things were in flux, as we all know. It started to stabilize around July 2020. So when we were starting to look at trends, we typically start from there. You can see final numbers, over 8,000 patients in psychiatry, over 300,000 encounters. On the primary care network side, over 30,000 patients. And as I'm looking at this, I actually think that encounters might be wrong. I need to check that. I think it might be higher. I'm not going to dwell too much. You can see here the sample breakdown of the patient population, but in the interest of time, I won't go into it, other than to make the point that I think I was making before, where if you look at Black patients, around 30% in psych and less around 20% in JCP, which was something I alluded to earlier. So if we just take those patients and we look at the completed outpatient encounters over time, this is from 2017 to June 2023, and this just represents the total number of completed appointments. The actual number didn't change right here. This is obviously COVID, March 2020, but you can see what did change is here's in blue is, or actually start with the orange, here's in person. It just plummeted, as we all know, it shut down, so that the number of appointments plummeted. And compensatorily, if that's a word, we had this increase in telehealth, dramatic. And then as you can see, over the past 2.5 years, they've been coming together and they're starting to stabilize, such that now going in the last 3-6 months, it's really been about 50-50. 50% of the outpatient encounters across the Department of Psychiatry among our patients with depression. I should be very specific here. We're only looking at our patients with depression and may differ by the patient population in the Department of Psychiatry. It's around 50-50. And I think as I continue to look at this data that it's somewhat stabilizing. It may be in-person's creeping up, but it's here to stay, it seems, telehealth. And around 40 to 50% of the encounters are telehealth. Primary care and Johns Hopkins Community Physician. Same rapid dropping in person, rapid rise in telehealth, but they quickly stabilized such that now around 70% of the outpatient encounters in GHCP among our patients, again, who have a depression diagnosis is in person, and around 30% is telehealth. Much different picture than what we see in psychiatry. It's actually different if you drill in on these patients. Again, these are patients in Johns Hopkins Community Physicians Primary Care. They've had a diagnosis anywhere of depression, but we're looking at all their appointments. And so a lot of those appointments are obviously for non-mental health related issues. What we did here is if we took those encounters where the primary diagnosis, where we thought the primary reason for the encounter was a depression, and we looked at that versus all the other encounters for those patients, we get what we see over here. Just focusing on the blue solid and the green solid line, this represents these patients, and we're just looking at their encounters where there was a primary diagnosis of depression. It looks like it's what we see in psychiatry. It's around 50-50. 50% of the time, they're doing it by virtual care. The primary reason for the care is depression. They're doing it virtually rather than in person. But for all their other encounters for these same patients, over 70% of those encounters, this is the dotted line here, is in person, and less than 25% is for in-health. Very different. However, for patients in Johns Hopkins Physician, if we look at those where the encounter is any depression, it's not a primary diagnosis, not the primary reason, again, focusing on the solid line, the proportion of those encounters where it might be a secondary or a third diagnosis, it's over almost 80% in person, and less than 20%. It's even more skewed toward the in-person. And so the bottom line here, it seems that patients in primary care, when they're want to go for depression care, that's their primary reason, they're likely to do it by telehealth. But when they go in for care, there might be another reason that comes up as part of the conversation while they're in person. And that's when they're getting, oh, I also am having struggling with depression. And that's what we're seeing with them in these encounters. So we wanted to look more closely at that. Okay, so these are completed appointments. So we are all familiar with the fact that not all appointments are completed. In fact, a large proportion, we'll talk about in a second, are no-shows or cancellations. And those are not good, both for the continuity of care for the patient. They're not good to the health system, especially no-shows, because we can't fill them. Those are slots that go unfilled. And so there are things that we want to reduce. So we set out, we wanted to try to look at what are the predictors of why patients are completing an appointment versus not, versus no-show or cancellation. And does it differ by telehealth versus in-person appointments? So we look at encounters for all our patients from July 1, 2020 to the current date, and we create this logistic regression model. We don't even know the details, but it's a way of estimating the probability that this appointment will be completed versus not as a function of patient-level characteristics or encounter-level characteristics that's represented by here, as a function of whether it's a telehealth visit or an in-person visit. And then we can actually include an interaction term to ask the question, well, does it differ for different types of patients if it's telehealth versus in person? Again, hopefully you're getting the idea that the notion is, can we use this to learn, are there certain types of patients where we do better? They're more likely to complete their appointment, they're less likely to cancel, less likely to no-show, if we can understand what types of patients this works best. So we do this logistic regression modeling. We do a random effects modeling to account for repeated observations. You don't need to pay attention to that. Just know that in the back of your mind. We show you a couple of slides where we take this model, we estimate the predicted probability of a completion based on this model, and we can look at the significance of the relative risk of these things happening, a completed versus a cancellation or a no-show, as a function of characteristics. So first, looking at just completion rates and cancellations and no-shows, just focusing on this panel over here. This is in psychiatry during this time frame. From that model, what is the probability of that appointment, that outpatient appointment, being completed by the patient? And you can see it's almost 75% if it's by telehealth, and it's much better than an in-person appointment. Perhaps not too surprising. It's around 65, 66%, 67% probability of a completion. And you can see there's a significant difference. Okay, great. Telehealth is going to do better in terms of completion. And we see the same thing down here, which is Johns Hopkins community physicians, taking that model I just showed you, looking at all these encounters post-COVID, predicted probability of completions around 80%. Well, then let's flip it. Let's look at cancellations versus completions, drill down specifically on cancellations. And you can see the probability of cancellation in psychiatry much higher if it was in person, around 25% cancellation rates versus around a 15% cancellation rate for again, same picture that you see down here in Johns Hopkins community physician. This odds ratio just is representing that the probability of a cancellation just less likely, that's less than one, is very significant, representative for a telehealth. So that's a good thing, right? It's suggesting telehealth might be a good way of improving access to care for our patients. There's a slight interesting phenomenon here, which we haven't quite pinned down, looking specifically now at cancellations, patient cancels, there's the opportunity to refill that time slot. No shows, they don't show up, it goes, that time slot goes empty. So it's a little bit more not a little bit, it's more costly to the healthcare system. We do a model looking specifically at no-shows, and we see actually slightly higher for telehealth in psychiatry. That is significant compared to in-person. And you can see it's around 8 to 9% probability of a no-show rate. This is, again, just among our patients with depression. I did see data actually in our meeting today where across the Department of Psychiatry, the no-show rate's around 12%. So apparently our patients with depression are doing slightly. But the idea is, okay, can we understand what are some of the factors that predict why some patients are able to complete their appointments versus not completing them, which is cancellations or no-shows. And so we've done some modeling to answer that question, and that's what's shown in this figure. These are different covariates that we're looking at just to orient you to the results. Again, from that same model that I showed you. What is a probability? Here we're looking at completion. Hopefully I'm not getting you confused going back and forth, but completion versus they canceled or no-showed. The green bars represent that estimated probability if it's a telehealth appointment. I should mention that the dot is the point estimate. The bars represent the 95% confidence interval. The orange represents what is that predicted probability if it's an in-person visit. And then what I'm showing down here is an interaction term, which asks the question, is the difference between telehealth and in-person, does it differ across levels of that specific covariate? Is there an interaction? Let me tell you what I mean. Just focusing on this variable, ADI. So this is area deprivation index. It's a measure of the area deprivation of a number of factors like the poverty rate from the zip code of where the patient is coming from. And higher scores represent higher SES. Higher scores represent lower SCS. And this fourth category represents, actually, there's a lot of missing from this data. And so this is the missing category. The point that you can start to see from the data is, if we look at the green estimated predicted probability, the appointment post-COVID being completed is uniformly higher for telehealth versus in-person visits. And it's significantly so, which is what we saw before. We are reaching more patients when we do telehealth than we do in person. And interestingly, though, the improvement in completion rates is different. It increases as we cross the ADI scales, as we go a higher SES status. And that's represented by these interaction terms, again, very. And just time is going quickly in the interest of time, flipping over to looking at patients who are Black, white, or other, we see a somewhat of a similar phenomenon. Again, regardless of racial or ethnic group, telehealth is doing a better job of getting completion rates for our patients. We're getting access to care. They're getting the care that they need. But we're seeing that the improvement is better. This difference is greater for patients who are white versus patients who are Black. Again, we see the same concept with insurance when we compare private insurance versus public insurance. It's an interesting phenomena that at one point that I wanted to highlight from looking at this data is that telehealth, it is improving access to care for everybody, but it's doing it in a different way. Disadvantaged populations, vulnerable populations, it's doing it less. It's increasing their access less than it is for more advantaged populations. So in the long run, while it's helping everybody, it does have this potential to continue to increase disparities between vulnerable groups. And it's a kind of an interesting question. It's a good thing because we're improving for everybody access, but at the same time, it has this negative side that it's how do we do it such a way that it's improving it for everybody rather than certain groups better than others. And this is a phenomena that seeing across different sorts of data that we're looking at from the HR data and the precision medicine center of excellence. In the interest of time, I'm going to skip this. And this, we actually looked at different factors related to the encounters. And you can see there are differences, whether we're talking about the time of day, what day of the week, the time of the month. Again, I'm not going to go into detail here. In other talks, we do go into more detail that talk about some of the interesting trends. Just real quickly, for example, the time of the day, you can see evening appointments, completion rates plummet for in-person. And we actually can maintain it by by doing virtual health in the evening. The little tidbits of information that might help us improve that. I'll stop there, but again, some interesting lessons to make. Final point of this project is that, so we've taken this model, and now here we wanted to flip it, and we wanted to create a prediction model, specifically drilling down on the no-show rates, which are costly to the healthcare system. Can we identify certain, whether it's patient or encounter level characteristics, or can we create a model that tells us this is more likely to be an encounter that's going to be a no-show? There should be some remediation. Should we do extra efforts to reach out to the patient or other sorts of strategies? We took that model, trained it on our data. We held out a portion of that data and said, how well could we predict the no-shows in those other sets of appointments? And this is what we get as an ROC curve, which we're all familiar with, which tells how well that prediction model is doing. We look at what's called the area under this curve, or the AUC, which tells us how well the prediction model. Typically, we want a model where that ROC curve really is bowed out away from this 45-degree line. Here you can see we got 65%, which is not great when we looked at these covariates. What's interesting, and the point that I did want to highlight from this, when we add to the model the patient's own history of a no-show rate, which gets better and better over time as we get experience with them, we dramatically do better in predicting their probability of a no-show rate up to areas of curve around 80%, which is getting to be clinically meaningful. And this is just early days. We continue to work on trying to refine this. But again, another thing that I'm seeing in a lot of the different analyses that we're seeing is that population covariates give us some information about how patients are doing, but there really is something about one's own history. And this might not be rocket science, we all know this, but there's unexplained variability by one's own history that tells us something about their future history. Again, we probably already know this, but it really is revealed when we start to look at this data. We are rapidly, significantly overestimated or underestimated the time, so I'm going to try to be a little bit more strategic about the data that I want to show. The second study was looking at trends for patients with bipolar disorder. How are we treating trends with regard to medications across Johns Hopkins? Here are the folks that have been really leading these analyses. Here I wanted to highlight Brandon Burkhead, who's a resident that many of you know, who's been just tremendous and sticking through the many challenges of pulling this analysis together. And so I wanted to thank him for all of his efforts. Quickly, the aims of this project. Okay, we wanted to describe what are the trends in prescribing lithium or these other treatments for bipolar disorder to treat patients with bipolar at Johns Hopkins. And in particular, how are we doing in terms of prescribing lithium patients with bipolar disorder against national trends? If you talk to the leading bipolarologists, Dr. DiPaolo, Dr. Potash, lithium is a tremendously beneficial treatment for bipolar disorder, but it's woefully underutilized across the country. Well, how are we doing here at Hopkins with regard to the lithium treatment? Likewise, there's this concern about treating patients with bipolar disorder with antidepressants. Is it a good thing? Is it a bad thing? Do we worry about treatment emergent mania? And we see a lot of that when we look at national trends. Well, how are we doing at Hopkins? And how does that differ when we look at different patient or encounter level factors? Can we understand what's driving whether we're doing a quote unquote good job of prescribing lithium or using antidepressants in an appropriate way? To motivate this is data from a student of mine who analyzed data from the National Ambulatory Medical Annual Survey across the country about patients with bipolar disorder over the last, over this period of 20 years from 1995 to 2015, what was happening with treatments. And there's just two things I wanted to point out to motivate one or two slides that I'm going to show here. The first is, here you can see, this is the rate of prescribing lithium to patients with bipolar disorder across the country. In 1995, around 40% of bipolar patients, we would see evidence that they were getting lithium. That plummeted over the last 20 years. So now we're around 15% of patients with bipolar disorder are getting treated with lithium. And compensating for that is just this dramatic rise in this purple line, which is the atypical antipsychotic. We're all familiar with this trend. This just makes it very clear and very stark, this national trend. And when we talk to the experts, there was the concern that why are we not using more lithium with our patients with bipolar? On the flip side, looking at antidepressants, overall, we see around 40% of our patients with bipolar disorder across the country are getting antidepressants. And perhaps even more worryingly, around 20 to 10%, 10 to 20%, I would say, it's been dropping, although it has started to stabilize, are getting these antidepressants without any other treatment or medication, a mood stabilizer. And so there's really this concern about treatment emergent manias. This is a good thing or bad thing. So it really is against that backdrop that we wanted to understand what we were doing at Hopkins. And so we looked at data from 2017 to up to 2022. There's around 3,000 to 4,000 patients every year we're seeing across the Johns Hopkins hospitals and Johns Hopkins community physicians that have bipolar disorder, and they're getting treated with a psychotropic medication. Here you can see around 30% patients back and a large number on public insurance. We are seeing a very diverse patient population. These are the trends that we see. It's been stable, flat, but we're only looking from 2017. We do that with our data, even though it stretches back to 2013 with Epic. 2017 is when it was enterprise-wide. All the healthcare, all the hospitals, community physicians were on Epic, so it was uniform across the health system. But as you can see, around 70% of patients with bipolar disorder year after year are getting treated with antipsychotic, whether it's the first generation or a second generation. And that's been consistent. Around 20%, 25% are getting treated with lithium. That's better than what we saw nationally, but not much better. And then antidepressants, again, very similar to what we see nationally, maybe even a little bit higher, around 45 to 50% of our patients with bipolar disorder year over year are getting treated with an antidepressant. I am pressed for time, so I am just going to make a couple of points here that we looked at a variety of characteristics to see, well, what's going on? Are there specific characteristics that explain why they're getting lithium or these different treatments? And that's what's represented by these different characteristics, their probability or percent of patients with bipolar disorder that are getting prescribed lithium. Not a whole lot going on by sex, although you can see females more likely to prescribe an antidepressant. We looked at age as a factor to see differences. And I apologize that I won't be able to spend more time, but I do want to make a couple of points and leave room for discussion. We looked at, there's an interest, is there differences by racial groups? And we do see a difference. So here's lithium patients. Here are patients who are white, and here are patients who are Black. The proportion of patients, Black patients getting treated with lithium is less, and it's significantly less. Not dramatically so, but it is less. While the converse is true with the neuroleptics. So something to keep in mind, the antipsychotics. White patients much less likely to be prescribed a first generation or second generation antipsychotic. We looked at public versus private insurance. We looked at by diagnosis, and this, I think, is what we would expect, that patients with bipolar I disorder are significantly more likely to be prescribed lithium, whereas patients with bipolar 2 significantly more likely to be prescribed antidepressants. Again, little nuggets of information that get revealed. Here's the last slide I wanted to show for this series of studies is looking across the Department of Psychiatry. We looked at primary care, that's in blue. We looked at mood disorder center patients. We took our docs who we consider part of the mood disorder center, who are experts in treating patients with mood disorders, and then other psychiatrists across the Department of Psychiatry. And as you would expect, our mood disorder clinicians are much more likely, significantly so, to prescribe lithium than other patients. Providers in primary care, they really do not like prescribing lithium. And again, that must probably conform to what we all think is. Likewise, for antipsychotics. Interesting for antidepressants, all the clinicians across this grouping were found equally likely to prescribe an antidepressant medication for patients with bipolar disorder. Final slide, we did want to look specifically at antidepressants. And again, this is antidepressants treated bipolar disorder. It's around 50%. We tried to look at where is the case that the patients are getting treated with antidepressants and there's no other evidence within a half-year window around this, any other psychotropic medication, mood stabilizing. It had changed, but it is around 15 to 20%, not too far off from the national trend. You do see this spike around COVID, which is interesting, but it is falling back down. So again, is that worrying? Is there a legitimate explanation? Something to continue to dig into. 1 minute, I will finish this last one, just to whet your appetite. Because all that's been descriptive. Now we really want to take our data and say, well, can we start to understand, are there ways to predict when we provide treatments, is there differences in the impact of that treatment on patients? This is a grant that's funded by P. Corey in collaboration with Liz Stewart, who's in the Department of Biostatistics. It's been a wonderful collaboration where we've been asking the question, is there evidence of treatment effect heterogeneity? And can we combine data from randomized trials that are out there with our real world data from the electronic health record? We get what we consider the best of the both worlds. Randomized trials give us sort of gold standard evidence, but they're typically small sample sizes, rarefied populations. Real world data, larger sample sizes, more heterogeneous, more real world populations. Can we combine evidence from both of those types of studies to really get an estimate for treatment effect heterogeneity, to learn something that we can then use to provide predictions and then recommendations back to patients? This is motivated by work where there's been a series of studies comparing duloxetine versus vortioxetine. There's in fact 4 randomized trials out there that have good quality data. And then we're looking at the EHR data to say, let's find patients in our registry who have been prescribed duloxetine. There's around 9,000 of those patients, or vortioxetine, around 900 patients. And can we start to do fancy methods with them to do what's called propensity score matching, to match them on characteristics so that we try to mimic the randomized trials. This is the kind of work that Liz does to draw meaningful causal inferences from observational data that we can compare randomized data and try to bring that data together, match patients in a way that allows us to come up with more valid inferences about the efficacy of duloxetine and vortioxetine from our real world data and combine that with the randomized data. I'm not going to go into the results of this. I did want to make one final point, and that is with the data that we have from the registry, we have distal outcomes like ED visits, or hospitalizations, or suicide-related ICD-10 codes. But these are rather distal, they're not the greatest. And so you've heard me talk a lot about work that I've been involved in, and a lot of that work is trying to, how can we make that EHR data better to get better outcome data so that we can then do these kinds of analyses that I just talked about. You've heard me talk about MyCare, this measurement-based care, and we've created all these workflows for implementing, let's get standardized patient-reported outcome measures on all our patients. The goal of that work has been, because it's good clinical care to do that, to measure how our patients are doing, to get these standardized reported outcome measures at every visit. But also at the same time, we can bring that data together into our PMAP registry, and then it becomes useful data to do the analysis that I just talked about, where we're severely limited at looking at outcome data because we don't have good outcome measures. And so this My Care effort really is driven by that work to make that kind of work more valuable. We also have supplemental funding to that Pete Corey grant with Liz to do some large language models, to do NLP on the clinical notes, to see if we can derive objective measures like the CGI from the clinical notes that we can then use for those downstream analyses. Again, to do the kinds of analyses more effectively with better outcome data. How do we make that EHR data more valuable to us for that learning health system? And a lot of the work that I've been involved in is doing this kind of work. I will end there. I had 1 minute. I realized, I'll make one last point. I was working on these slides in Doha while we were waiting for a connecting flight at midnight last night, I guess. And I realized I didn't have any summary slides, probably a good thing because I would have run over time. But I will say that in summary, this is work in progress. We're learning, trying to leverage the resources that are available to us to do a better job of learning from the EHR data. We're trying to, what we learn, we want to share with others. And so thankful to the health system for providing an infrastructure, thankful to the philanthropic funders who have supported this work, and then finally thankful to the folks that you see here who have really made that work happen. I do apologize, Jimmy, that I went over. There was a lot of ground to cover, and I was quick at the end, but hopefully you get the gist of the kind of work in the center. And hopefully we can share with others to take advantage of the same kind of work that we're doing. Sorry, Jimmy, a mouthful.
Thanks, Peter. It is absolutely fascinating work and really interesting presentation, which generated a number of comments and questions in the chat, which unfortunately we're not going to have time for because we are out of time. But thanks for taking that long trip to Saudi Arabia, to Johns Hopkins Aramco Health, and hope things go well over there. And certainly, folks, if you have questions, I'm sure Peter will be happy to respond to any things you might want to ask him via email. All right. Thanks, everybody, for joining. Take care.
Thank you.